Hello, my name is Michael Loria, and this is Patient Refusal and Capacity Assessment. So, by way of background, I started out in EMS in the early 2000s as a firefighter EMT. I worked or enlisted in the Air Force as a pararescueman in 2005. My job was providing combat search and rescue capability to different special operations teams around the world, as well as direct action support for some of those teams until about 2011. I got out and I stayed in EMS. I worked as a flight paramedic for the Dartmouth Hitchcock Advanced Response Team and ultimately went to medical school. I ended up here in New Mexico for emergency medicine residency, emergency medical services fellowship, and I'm currently a critical care fellow here at the University of New Mexico as well. That whole time, I still haven't been able to get away from EMS and my love for flying. I've been working as a flight physician for the Lifeguard Air Emergency Services program. In terms of other disclaimers and disclosures, I am the Associate Medical Director for Lifeguard Air Emergency Services, as well as the Chief Medical Director for a company called Flight Bridge Ed, helping them in their development and delivery of educational materials, and really no other financial conflict of interest at all. So, this talk is about patients that refuse to go to the emergency department and get evaluated, especially patients that were concerned actually might have some sort of medical emergency going on. And so, what I'm going to do is I'm going to talk about the ethics and legality of refusals and assessing if patients have the capacity to refuse, allowing refusal or forcing transport, go through, I think, some really important points in the capacity assessment, some big changes in my practice that I think are really, really important for EMS personnel, and then finally talk about mental health and refusal. This is a really, really critical subtype, if you will, of refusal that I think warrants addressing it in particularly, and then finally, management. If we have to force these patients to go to the hospital, how we manage them. So let's talk about ethics and legality. This is really kind of a sticky subject, and we have to be careful and apply various ethical concepts and be aware of the law before we, or as we get into seeing if patients can refuse to go to the hospital or not. For example, we encounter patients all the time. Their families are worried about them. They think they may or may not have dementia. They're a little bit concerned, but that patient doesn't want to go. Take Beth, for instance. She's a 78-year-old lady whose family thinks she might have dementia. She tends to forget things all the time, and they're a little bit concerned because she fell down at home, and they say that she's been falling down several times over the past month, and their family's very concerned. They want her to go and are saying she has to go to the hospital, and we as EMS providers have to take her. But Beth is very adamant that she does not want to go. Or about Earl. He's a 70-year-old gentleman with hypertension, hyperlipidemia, and type 2 diabetes that we were called about, or we were called to the rodeo for, because he was having some intermittent chest pain. You get this really, really scary, concerning EKG consistent with what very well may be a myocardial infarction. In fact, does meet STEMI criteria, and Earl does not want to go. Flat out refuses to go to the hospital. Well, as it turns out, patients can make what we may consider to be bad decisions for their health care. Even though an emergency medical condition may exist, and we know that there's a way to treat it, a way to help these people, they don't necessarily have to go to the hospital. And as we look at it through the lens of ethics, of looking at it in terms of applying moral principles of what's right and wrong of how we deliver emergency care in the field and transport these patients, we have to consider essentially what are the four tenets of ethics when it comes to medical care, with which are justice, so fair and equal treatment of all patients; beneficence, so doing the right and appropriate thing for a patient; non-maleficence, so avoiding harm, injury, pain, suffering, or loss of dignity as well; And of course, autonomy, the right of a patient to make decisions for themselves. And really, here what we're trying to balance is beneficence and autonomy. We're trying to do the right thing to provide the right emergency medical care for a patient, but we have to respect their autonomy, their right to make a decision. You could even make an argument that there is a component of non-maleficence here. We have to respect their dignity or not violate their dignity, as well as do harm to them. Um, Autonomy, in particular, is an interesting concept here because we consider it the legal right of competent adults to make informed decisions about their care. So this is very important. This is an important piece of the puzzle because in order to maintain autonomy, that person must be competent, and they must be able to make informed decisions about their care, which we will get into here shortly. But in general, we have to respect people's autonomy, and the scales of justice weigh heavily in the favor of individual autonomy, at least, especially in our state, in the state of New Mexico, but I would argue across the country as well. Now, this is really, really important because patients have the legal right to refuse medical care. In fact, it's a fundamental right that we respect here in the United States of America, is that we have the right to say no, to not have procedures done to us, to not have medical care applied to us, to not get taken out of our homes and dragged to the hospital. And in fact, if we are transporting patients against their will and violating their autonomy, if they have the ability to be autonomous, then that is essentially kidnapping, right? That is restraining a person and taking away their liberty either by force or show of force with a bunch of firefighters and police officers around us, and taking them from their home or taking them from wherever that and moving them to the hospital. That is really not okay on so many levels. Not that just illegal, but we have to maintain the public trust that we are doing the right thing for patients, and that trust in the public when they call 911 that we're going to be there to help take care of them and do the right thing is so, so important on so many different levels. So now let's get into allowing them to refuse or forcing patients to be transported. Can be very, very tricky sometimes. But imagine you have a patient you think might have a life-threatening problem. They're alert and oriented times force. They're awake, they're talking to you. Can they refuse? Well, what do? How do you decide if this person has the right to be autonomous? And at least in the state of New Mexico, the New Mexico EMS Act is fairly clear on this, and that we can force a person to go to the hospital if we are making a quote, a good faith judgment that that person is incapable of making an informed decision about his or her own safety or need for medical attention and is reasonably likely to suffer disability or death without the medical intervention available at such a facility. So, this really is the crux of the issue, that you really need two things. If you're going to force someone to go to the hospital, you have to clearly establish two things. One, there's a life threat that exists or is suspected, and two, the patient does not have capacity to make an informed decision. Well, usually the first part's pretty straightforward. Is there a medical life threat? There's a host of complaints that are pretty concerning. So if someone has chest pain and their blood pressure's low and they look sweaty and they're tachycardic, we can very easily establish that there's a life threat. And in the field, this is actually a little bit easier to establish a life threat because we don't have the ability to rule out a life threat, right? We don't have a lab, we can't take chest X-rays or do CT scans, so it's fairly, and we should be, have a fairly high index of suspicion that something bad could really be going on here until a patient is completely evaluated in the emergency department. Now, the trickier thing is, can they make an informed choice? And this comes down to their ability to consistently understand and accept the risks of that choice. And really, do they have the ability to be autonomous? Do they have the capacity to make decisions or make informed decisions? This brings up an important point, and I want to go over this because this is really critical. Understanding capacity versus competence here is kind of important. Capacity, when we say someone has capacity, they have the ability to make an informed decision right now under these circumstances. This can be assessed by anybody, an EMT basic, an EMT intermediate, paramedic, a doctor, nurse practitioner, you name it. Any healthcare professional can perform an assessment to see if this person really has capacity at the moment. This can change. For example, if a patient was completely fine, you went out to their house and their sugar was high, and you checked them out and they absolutely had capacity, they were completely with it, and then they took maybe a little too much insulin, and their family member calls you back an hour later. Now the person is garbling their words, barely able to stay awake, talking and saying nonsensical things. That person had capacity, but that has completely changed, and now they do not. You can take that in comparison to competence. Competence is a legal condition decided by a judge in a court of law that usually establishes guardianship. So a person is deemed incompetent to make decisions for themselves or not competent to make decisions for themselves. And the court will often essentially establish a guardian that will make decisions on that person's behalf. Now, we've established that critical to understanding can we allow someone to refuse or force transport is understanding capacity. Does someone have capacity? And I want to go through at least how I do my capacity assessment and encourage providers that I've trained to do, EMS providers that I've trained to do their capacity assessment. Well, the first two pieces are pretty straightforward, and most people understand this, but I'm going to throw it out there. One, the person obviously has to be awake, alert, and oriented. If they, say it's Monday and it's actually Tuesday, or they say it's Monday, because it's actually Tuesday because it's 1 a.m. There's some room for interpretation there, right? But in general, they have to be awake, alert, and oriented. They also can't be clinically intoxicated or under the influence of any substances. So this is really important. It's a clinical evaluation of if you think whatever substances they may or may not have taken, whatever medical condition is going on, is affecting their judgment. So specifically, it's not just, did the person have one alcoholic beverage 2 hours ago or three alcoholic beverages an hour ago? It is essentially your clinical assessment on scene because you don't have a breathalyzer or any drug tests. But what this is essentially asking is there evidence to you, talking to this person, that their movement's impaired? Can the person stand up? Can they walk generally in a straight line or hold themselves up and turn around without losing balance and falling over? Can they see? Are they walking into objects? Can they hold focus on you when you're having a conversation? Do they have clear speech? Is their speech garbled or incomprehensible, or is it clear, just like I'm talking to you right now? Their judgment. This is, if they decide to, run into traffic because of what's going on, these substances that are apparent, then that's clearly demonstrating poor judgment and generally how they appear. Do they appear, like all completely disheveled and appear like they are under the influence of substances, not caring about their appearance or how they're talking to you, appearing, have they peed on themselves or defecated on themselves? Those sort of things you have to put together into your clinical appraisal of whether you think this person is intoxicated or not. This brings us to the other key pieces of capacity. So you have to be awake, alert, and oriented. You can't be intoxicated, and you have to be able to do these four things: comprehend, choose, reason, and appreciate. I'll say it again. These are the four big ones. You have to comprehend, choose, reason, and appreciate. And so what I say is, in order to have capacity, you must be able to, one, you have to have the ability to understand and comprehend one's current situation and condition, what's going on around you. Number two, You have to have the ability to make a decision or a choice, and that choice has to be clear and consistent. If someone's waffling back and forth and not choosing and then choosing and saying they don't want to go to the hospital and saying they want to go, that is not a clear, consistent choice. They have to be able to reason or rationalize their decision, explain why they're doing it, and lastly, clearly understand and appreciate the consequences of their decisions. Now, I say this is really important, and this is really the meat and potatoes of this talk because this is what I want you guys to take away from this talk. Those first two pieces are generally pretty straightforward and most people understand, but I gotta tell you, when I first learned these things, I didn't really know how to assess these things. And my capacity assessment went somewhere like this. Hey, ma'am, you understand that you might be having a heart attack or you could even die if we don't take you to the hospital. Do you understand that? Patient says, uh-huh. Okay, great. Well, can you do me a favor and sign this piece of paper that says you're refusing to be transported to the hospital, and if things get worse, let me know or call 911 again and we'll come back and take you to the hospital. That was about it. So I basically gave myself an F, maybe a D minus on my ability to do a capacity assessment in the field. But as it turns out, it doesn't take much to make that capacity assessment an A or an A plus. And here's how, okay? So I really started to think about this when I saw people, especially our providers in psychiatry, do these patient assessments in the hospital. The way they actually evaluate someone at the bedside, it's actually a very in-depth, nuanced conversation. Sometimes it could take an hour or longer. Now, I'm not necessarily saying we have an hour to hang out on scene and have an in-depth psychiatric assessment, nor am I saying that we necessarily have the ability or skill that a psychiatrist will have when assessing these things. However, there's an important nugget that I took away from watching them do this is that they are having a conversation with the patient. Much like I learned watching interrogators, both in law enforcement and the military, interrogate subjects. Like if you actually talk to them, what they're doing is they are trying to have a conversation with someone to leverage various things they know about them to slowly extract pieces of information. They're not sitting there like in the movies screaming at them, asking them why they did it. It's a very interesting conversation where they take turns and twists and turns throughout the conversation to basically follow where that person wants to go in the conversation, and along the way subtly extract information from them. Again, I'm not saying we should manipulate people, but that the nugget is there, the conversation. It's not like this series of highly structured checklist questions. They're having a conversation. And that's really important because conversations, just the way we talk to people, and if we make these questions more conversational and open-ended, we can learn a lot from people. Just like you're interviewing someone on TV as much as you might be interviewing someone or interrogating someone, that is both informative and you're able to extract a lot of information. And most importantly for us, not necessarily for entertainment's sake like on TV, but getting the patient to understand or having the patient appreciate that you understand where they're coming from and building this bond of trust with the patient. So here's how I do it. Here is how I actually go through these important capacity questions. First, the ability to understand one situation and condition. So I kind of get to this by just asking the person, what happened that you called 911? Or do you know why your family members called an ambulance for you? What do you think could be going on here? This is especially helpful if I'm coming in secondarily. In other words, someone has already told them, "Hey, I'm really concerned based upon this EKG that you're having a heart attack." Do they understand and appreciate that? Do they remember what they were told 5 minutes ago by the paramedic who was first on scene? I'll ask some other questions like, "Hey, how did you get here? Where were you headed? What were you doing? Were you cooking? Or what were you doing? What were you cooking? What were you working on? What project were you working on in your garage?" Things that are somewhat conversational, but also things that elicit, does the patient actually know what was going on? Do they know that they were working in their wood shop when they collapsed or syncopized? Do they know that they were cooking chicken or steak or whatever meal is actually in the kitchen when they collapsed on the floor. These are really simple questions that people who have capacity will be able to answer. Making a decision that's clear and consistent. This one is actually relatively straightforward. There's not a lot of conversation that you need to kind of get through this one. Over the course of the conversation, I just assess, is their decision consistent? Are they waffling back and forth? They want to go and they don't want to go. They told law enforcement and they told the initial paramedic on scene that they wanted to go, but then they turned around and said, no, they don't want to go. And now they're telling me at the beginning of the conversation, oh, I'll go. And then halfway through the conversation, when they're having it with me as the medical control physician, they actually turn around and change their mind again. Or they simply say, I don't know what I want to do. Things like that all point to the fact that they're really not able to make a clear and consistent decision. 3 is a little bit more nuanced, right? They have to reason or rationalize their decision. And I'll just ask them pretty straightforward, why don't you want to go to the hospital? Everybody's really concerned about you. Your daughter's very concerned about you. Your son watched you collapse onto the floor. They're really worried about you. Why don't you want to go to the hospital? Why do you want to stay at home? What are you concerned about? Oh, I'm concerned about that. I have several animals here. No one can take care of them. I'm concerned that someone's going to break into my house because I'm not at home to supervise or watch my house. I'll ask them other things in terms of rationalizing their decision. If we tell them we're concerned they might die about something, do they have other plans to seek health care or see a doctor? And if you ask about, and sometimes patients will say, you know what, my chest pain is gone now. I understand I have to stay home because I'm taking care of my elderly wife and no one else is around to take care of her. I will try to arrange for my children to come in the morning, and I'll try to come to the emergency department in the morning to get checked out. Or I promise I have easy access to the phone. If I have chest pain come, I'll call 911. Whatever that may be, they have to clearly rationalize that or justify their decision, or at least explain their thought process. We don't have to agree with it necessarily, but they have to be able to reason through it and explain it. And here's the big one: clearly understand and accept the consequences of the decision. Again, this is where I see a lot of pitfalls, and I see a lot of EMS providers gloss over this one. I will very often say, hey, they understand that they could die, or they understand there could be an emergency, and they get it. But do they really? Just asking them or explaining to them and them saying yes does not necessarily mean they appreciate the consequences and they accept those consequences. So I will ask them more open-ended questions here, like, what do you think would happen if your condition got worse? Sometimes I will even give them a hypothetical scenario that's relatively pointed, that will be related to what's going on with them. So let's say that was a call for difficulty breathing, or asthma, or COPD exacerbation. I'll ask them, what do you think? I'm really concerned that we're giving you lots of oxygen right now. We're giving you a lot of medications through this nebulizer device to help your breathing. But now I know you don't want to go to the hospital, but what do you think would happen if your breathing got way worse and you just stopped breathing? Or if they were having chest pain, I was concerned about them having a heart attack, your heart were to stop. Or if they were having a stroke, what do you think would happen if you collapsed and you were unable to move one side of your body, or the stroke caused you to lose consciousness, or the stroke affected your brain so much that you stopped breathing? Most rational people should be able to explain, well, if I stopped breathing, I would die, or if my heart stopped, I would die. They can explain that to me, like, you know what, if my heart stopped, I would die, and I'm okay with that. I've lived a good life. I don't want to be resuscitated. I don't want to have a breathing tube in, and I'm okay with that. I'll just die peacefully at home. Well, okay. That is very different than telling someone, hey, you could die, right? Or, hey, I'm concerned you might be having a heart attack. If your heart could stop and you could die, and they say, uh-huh. That's very different from them opening it clearly, understanding the information, processing it, and spitting back to you a response, a cogent response explaining what might happen. You usually get questions, well, what about what if they're on oxygen? What if what if they are getting medicines right now? We've given them, sugar, and their blood sugar's up right now, but I'm concerned that insulin could have an effect. Well, as it turns out, the purpose of this capacity assessment is to understand what's going on right now in the whatever clinical or physiologic milieu they're experiencing right now. Um, that that response is that these questions are eliciting if their brain is working under the current circumstances. If you do the assessment as is with that support, then that is a valid assessment, a valid capacity assessment. I will often, if they say that they don't want the support, they don't want these medicines, they don't want anything, it is very reasonable to provide them, and we'll talk about this a little bit later, provide them medical care, stop the oxygen if they want you to leave and they pass the capacity assessment, and as you're leaving, check on them to make sure that now without the oxygen, they're not falling asleep or losing consciousness or unable, or now all of a sudden do not have capacity to make a decision. Because remember, that capacity can change. So let's try some little mini scenarios here to highlight some of these really important points. First, let's go back to Earl, right? So Earl is actually at the rodeo. And Earl was a professional bull rider for a long, long time, and now he is volunteering with the PBR. He goes to all of the PBR events, and he was there tonight helping out as a volunteer. And all of a sudden, he developed some chest pain. He looked like he got kind of sweaty. A bunch of the other volunteers were concerned. They called basically the event EMS personnel to have them check on Earl. And they were really concerned because their 12 lead indicated that he was very clearly indicated that he was having a STEMI. So this is a clear medical emergency that we know we can address, we can fix, we can help Earl with, and it could be lethal. Absolutely could be lethal, right? But Earl doesn't want to go. Very clearly does not want to go. He hasn't been drinking. He's alert, oriented. He's completely with it. He's sitting there in the chair, tells you he doesn't want to go. So you ask Earl, what's been going on? What have you been up to today? Why did they call 911? Well, they called 911 because they were really concerned about me. I came here, I drove here from my home in California to be part of this rodeo, and I was helping out, feeling fine all night. I was standing up here, checking tickets, and all of a sudden I started to have this chest pain. This is what the chest pain felt like. I felt kind of dizzy. I sat down. They called 911. He's very clearly, he knows what's going on. He's very adamant and very consistent in his decision that he doesn't want to go to the hospital. And you ask him why. And Earl says, well, you know what? My wife died about 6 months ago. My nephew is riding bulls in this competition. And you know what? That's the last thing I want. This might be his last year on the pro rodeo circuit, on the PBR circuit. And I just want to watch him one last time. Because as it turns out, I have cancer too, and I don't know how much longer I'm going to be around. But I just want to watch him in the rodeo one last time. And in fact, he explains that after he watches his nephew in the rodeo, he will have one of his friends, one of his co-volunteers, drive him to the emergency department. But he is adamant that he does not want to go right now, and he doesn't want to go in an ambulance. You explain to him the situation. You tell him he may not last that long. He could die at any point. There's very clear evidence, very, very, very clear evidence based upon the EKG and in accordance with his symptoms that he could really be having a heart attack right now, and he may not last that long. And you ask him, like if we were to leave you here, and the heart attack got worse, that arteries to your heart's really plugged off, and your heart were to stop, what do you think would happen? And he says, well, you know what? I would die. And I'm okay with that. I'll go to my maker. I don't want CPR. I don't want to have a breathing tube put in. I'm fine. I've lived a full life, and I'm happy to go meet my maker, and I'm happy to go meet my wife in heaven. Okay. Earl is alert and oriented. He is not intoxicated. He knows exactly what's going on. He expresses a very clear and consistent choice. He has a reasonable rationale for why he wants to stay there. And in fact, he has a plan for what he's going to do. He's reasonable and will seek medical care, just doesn't want to go in an ambulance and doesn't want you to take him now. And he very clearly understands the consequences and accepts them and is at peace with them. And that's okay. So Earl has capacity to refuse. We'll have him sign the paperwork and follow all our local protocols for refusal of transport. But he does have capacity, even though he's having a very clear ST elevation MI. He has capacity, and we cannot force him to go to the hospital. Let's talk about Dolores. Dolores is an 86-year-old lady. She keeps on falling, and now she has some wrist pain. And her daughter called you because she found Dolores on the ground, and she was holding her wrist and saying she's having some wrist pain. But now that the ambulance has shown up, Dolores does not want to go to the hospital. Does not want to go to the hospital. Her daughter's really concerned because she thinks that she's been falling and passing out, quote unquote, multiple times, and is concerned and wants her to get evaluated. So you start talking to Dolores, and Dolores gives you a relatively vague answer when she asks you what she was doing and what's been going on. She says, "Oh, I've just been taking care of things around the house and I fell." She's kind of unclear of the details of exactly what happened, but she knows that she fell and she knows that she hurt her wrist. She's pretty consistent and clear in her adamant refusal to go to the hospital. And when you ask her why, she says, "Well, I just don't want to go to the hospital. The emergency department is crowded. I have my dog here at home, and I just don't want to go to the hospital. And I've been told that the COVID virus is still around, and people, in that waiting room, I'm sure they're coughing, and I don't want to get sick. I'm old." Okay, well, it's not unreasonable. The emergency department is not the most, friendly and cozy of places. And there are certainly sick people in the waiting room. So her explanation of why she doesn't want to go is not terribly unreasonable. But then you ask, "Hey, Dolores, I'm really concerned. Your daughter says that you've been falling all this time. What do you think would happen if you fell down and hit your head and you didn't wake up? Or you fell down and you hit your head so hard it caused bleeding in your brain and that caused you to stop breathing for some reason. What do you think would happen if you passed out here and stopped breathing?" And Dolores looks at you and says, "Oh, sweetie, I'll be fine. I'll be fine. I'd be fine. My daughter would come and get me." Well, now this is suspect a little bit, right? She clearly would not be fine if she stopped breathing. She can't really brush this off and say if I passed out and stopped breathing and was collapsed on the ground that her daughter would come and get her. Right? That doesn't make sense. She couldn't call for help. No one's around to help her. She lives at home alone. I don't really think that she can appreciate the consequences of what may happen if she falls and passes out again. I don't think her answer really meets the threshold for understanding and appreciating the consequences of her decision being left home here alone. You explain that to her daughter, and her daughter agrees that she doesn't really think her mom's quite with it. And when she's answering these questions that you were asking, doesn't really have capacity to make decisions on her own. So you convince Dolores and take her ultimately to the hospital with her daughter's understanding of the situation. Let's talk about John, different patient. So you're called to the house of a 34-year-old gentleman who is known to be schizophrenic, and his family is concerned that he's not taking his medication. They haven't heard from him in several days. They call in a welfare check. Police go to the door. He opens the door for them, but he's clearly kind of paranoid, wringing his hands, and he tells the police that he's staying in his house because he's concerned that, quote, "they keep on coming and trying to turn on the gas in my house. They're trying to blow up my house." The fire department's called because, one, they need to make sure there's no actual gas turned on in the house, and two, they're concerned about his mental health, and the cops say, "Man, this guy needs to go get evaluated by psych." So the fire department gets on scene. There's no gas in the house. What they find is all of his antipsychotic medications fully filled more than a week ago, and the bottles look to be full. It appears he hasn't been taking his medicines. The house is actually very well organized. There's no evidence of that he's not taking care of himself. The kitchen is clean. There's some leftover food in the refrigerator, but otherwise, everything in the house appears to be organized and okay. John sitting there politely on the couch. He explains the situation. He keeps on having these recurrent paranoid delusions that people are coming to turn on the gas in his house. But he's refusing to go get psychiatric care at this point. He's refusing. He says, "I don't like taking these medicines. I don't want to go get evaluated by that psychiatrist again. I don't want to go. I have to stay here. I have to stay here." But then he'll flip flop back and forth and say, "But I'm worried here. I'm scared here because they keep on coming in and trying to turn on my gas." Well, this is an interesting situation, right? Because John, there's no clear imminent threat of danger to his life. He's sitting in his house, he's watching TV, he's peering out the window. There's no evidence that he's taken care of himself. There's no evidence that he's neglected himself. He's dressed cleanly. He's just having these paranoid delusions. He's clearly presented no threat that anybody knows of to any of the neighbors. He hasn't demonstrated any dangerous behavior. His vital signs are all within normal limits, and there's no clinical evidence that EKG is completely normal, and there's no clinical evidence that there's really a life threat. He doesn't necessarily have capacity because he doesn't really answer questions about his rationale appropriately, or completely, and is specifically refusing to answer question number 4. And you really can't assess whether or not he understands the consequences of not taking his medicine or going to get psychiatric help. So he doesn't have capacity. But he also doesn't clearly have a life threat going on. And as a result of that, just because someone is experiencing mental health issues, depression, or in this case, schizophrenia, because John is not taking his medications that he's been prescribed, does not necessarily mean that we can force them out of their house. Doesn't necessarily mean we can restrain them, give them medications, and take them out of their house unless we think that they're a danger to themselves, there's a danger to others, or there is an acute medical condition going on that is a threat to their life. In this case, there's really not. So we can't, even though there's a medical condition or a psychiatric condition going on, we can't just force John out of his house. Now, let's talk about Guy. Guy is a 62-year-old male who thinks he's Santa Claus. Very clearly thinks he's Santa Claus. And you get called by the police because they found him sprinting across a 3-lane surface street, going from house to house, trying to deliver presents to people, according to him. On arrival, you talk to him and you do a capacity assessment. His vital signs are normal, maybe slightly tachycardic with a heart rate in the high 90s, intermittently jumping up into the low 100s, but no clear dysrhythmia. And in talking to Guy, he clearly does not have capacity to make decisions. He is under the impression that he is, in fact, Santa Claus. He's doing what he's doing because he's trying to deliver presents to people. That's his rationale. He won't come to the hospital or won't come get evaluated with you because he is saying that he's Santa Claus and he needs to deliver all these presents. By the way, there's no presents around. He insists that no one's going to take care of his reindeer. Also, no presents, no sleigh, no reindeer, and that's why he doesn't want to go to the hospital. You specifically ask him, "Hey, you were dodging traffic, running around the street, going from house to house. Do you think that's safe?" And he says, "I'll be fine. There's nothing wrong with it." Clearly, he's Santa Claus. And you ask him specifically, "What happens if you were to not see? It's nighttime. It's dark out, Guy. Like, what happens if a car hits you?" He says that no cars are going to hit him. He's Santa Claus and he has magical powers. Okay. Guy clearly fails the capacity assessment. But this is a little bit different from the last example of John. Guy may be having an underlying psychiatric problem here, but he's clearly presenting a danger to himself. He doesn't realize the consequences of him running through traffic with cars honking at him. If he gets hit by a car, that is obviously a very dangerous situation. He could get really seriously injured. So, under these circumstances, based upon his behavior, Guy is doing things that present a clear danger to him or the public, right? If someone were to swerve and miss Guy in the middle of the road and crash into something, they could get hurt too. And he very clearly does not have capacity. So, under these circumstances, it is appropriate to force transport and to make sure that Guy gets taken care of. Now, we had those last two scenarios, and we didn't really talk about it, but I do want to go over mental health and refusal because this is something that comes up all the time, specifically suicide, homicide, and aggressive or agitated behavior. Now, remember, in the absence of these things, with a person who might be having a medical condition, like our first two patients, like Earl or Dolores, the scales of justice weigh heavily in preserving the autonomy of those individuals. This is a little bit different. In the case of suicidality, homicidality, or aggressive agitated behavior in the face of a psychiatric condition, for example, the scales weigh heavily in favor of justice. The burden of proof to let someone not go to the hospital or refuse transport is much, much, much higher under these circumstances. And we run into really challenging situations sometimes, like he said, she said situations. People who said, well, my friend, I'm really concerned about them because they said they wanted to kill themselves. And the friend says, no, I didn't. I never said that, right? There's no evidence that any of this was said. And we can get into some really hairy situations. But in general, the way I think about it, these are the guidelines that I use. If someone calls me and says, hey, this person wants to refuse and I'm concerned about a mental health issue or suicidality or something, here's the steps that I go through. So first of all, they have to be alert and oriented times 4. Can't be intoxicated, and they have to have capacity, right? There's no evidence of organic or medical provocation. They're not high on drugs or anything else that could be driving these suicidal statements or agitated behavior. There's no history of serious depression, suicidal ideation, suicide attempt, or serious underlying psychiatric disease like schizophrenia, like bipolar depression, like major depression. None of those things that would be high risk conditions for suicidality or behavior that would result in harm to themselves or harm to other people. There can be no active or clear evidence of SI, HI, so suicidal ideation, homicidal ideation, or aggressive behavior. So if they were punching through windows or pointing guns at people or jumping through traffic, these are clearly behaviors that demonstrate or are evidence of issues with self-harm, agitation, or at least neglect for self-safety or the safety of others, right? I will point out here that that this means it can be no evidence. That evidence can sometimes these days be videotaped, recorded, or screenshots of texts that a person may have said, and they're then showed to the police department and to the fire department. Those are all evidence, could be evidence of suicidal ideation or homicidal ideation. 5, no specific or directed statements. So it's very different when someone says, I'm just done, I can't take it anymore, I'm just going to end it, versus a text to a friend saying, thank you for everything, I am going to go and jump off this building, or I'm just going to take all these drugs and I'm going to go to sleep and never wake up again. Those are very different things. Specific behaviors, when someone states those things, that's really a pretty high threshold. That's really a pretty clear threshold for me. This person has thought through it, specifically what they're going to do, and has gone that extra step. And that to me is dangerous, especially when they have a plan. So that person, if they did have a plan, would require evaluation, needs to go to the hospital. They should have social support and the ability to access mental health. They don't necessarily have to have their own psychiatrist, but they need to have an alternate method, support from the family that's going to watch them, take care of them, friends that will help them and take them seek mental health support if they refuse to transport. So again, There's a lot here. They have to meet a pretty high threshold if we're going to let them not be evaluated and there's a safety concern. Now, law enforcement often gets involved in these cases, and that's okay, even if we deem that they have capacity. There is not a immediate threat to them or other people, and we think that we can't force them to go to the hospital. We can't force transport. Law enforcement does have that ability. So a sworn law enforcement officer, specifically in the state of New Mexico, I always tell people you got to check your state statutes, has the ability to detain and transport a person for mental health evaluation and care in the absence of a legally valid order from the courts if that person is otherwise subject to lawful arrest, they believe the person has attempted suicide or attempted to harm themselves, that person presents a serious risk of harm to them or other people, like running in and out of traffic, for example, or they have a signed certificate of evaluation from a medical professional that says that this person cannot refuse transport and needs to be brought to the hospital. Which brings us to the point of the certificate of evaluation. At least in my state of New Mexico, when this issue is given to law enforcement, it really is a law enforcement issue. You can kind of think of this as a warrant for mental health evaluation. A piece of paper is given to a sworn law enforcement officer, and that law enforcement officer is essentially detaining that individual at their home or place of business or wherever and bringing them for psychiatric evaluation. Law enforcement can do that. In general, law enforcement doesn't or shouldn't necessarily be calling calling EMS to transport these people unless there is a clear concern about their medical health or well-being. For example, they went to issue the COV and the certificate evaluation. The person right in front of them cut their wrists open, or they tried to run away from law enforcement and tripped and fell downstairs. Now they clearly have a pretty bad laceration in their head and they're bleeding. These are situations where, yes, we should get involved and probably bring these people for medical assessment and make sure they are medically stable before getting their psychiatric assessment. So now let's talk about management. This is so important. So there is so much that we can do to help these people out, even if they don't want to go to the hospital. And if we have to take them or force them, we have to be very careful about how we do it. So negotiate if you can. You do whatever it takes to a point. Offer them a sandwich. Tell them they can get food in the emergency department. Tell them that maybe we can negotiate and can a family member watch their dog for them? Can a neighbor take care of their house or offer to watch their house for them? Can we meet whatever their concerns are that they don't want to go to the hospital? We should also offer reasonable treatment. Um, we should, if they're having chest pain, you can offer them medications to take their chest pain away. If they are, offer them an aspirin. You can even offer them nitroglycerin as long as we take a blood pressure afterwards and make sure they tolerate the medication. If they're having problems breathing, we can give them nebulizers, you can give them steroids, whatever is within the scope of care. The only thing I wouldn't do is give them anything that can make them sleepy or alter their mentation, giving them anti-anxiolytic medications or benzodiazepines or anything along those lines. I think we got to be very, very careful under those circumstances. But otherwise, we need to show that we're doing everything to help them, even if they don't want to go to the hospital. And, oh, by the way, tell them, just call them back. We'll come back and help you if you need it. Now let's skip to the part where they can't refuse. So you've determined they don't have capacity. They don't want to go, and we need to bring them to the hospital. We think there could be a medical emergency going on or because of their mental health issue. Well, I always tell people safety is your priority. Get help. Get law enforcement. Get additional help from the fire department. Get the people you need to safely, potentially restrain this person and bring them for evaluation. If you live in a very rural place where you can't get that help, or it's just going to be you and this person in the back of the ambulance, and let's say you can't give them medicines to calm them down, and you're worried about your safety, this may be a situation where you need to call medical control and talk to them about the situation. And it actually may be an exception in the sense that, um, you know, you don't transport them because you're worried that they could actually really hurt you or hurt themselves and you won't be able to stop them. Now, let's say you do have help. You've got additional responders there. Law enforcement agrees to help you. Under those circumstances, I would encourage you, I beg you, use the least aggressive or least hands on means possible to take care of this person. In other words, clearly demonstrate that you're trying to verbally de escalate the situation. Offer them help. If they're experiencing a psychiatric condition, you can offer them, in up to the scope of your practice, offer them medications to help out and try to calm them down. If you have to restrain them under any circumstance, I encourage you to do what I call is medicalizing the restraint. Medicalize restraint interventions while they're getting medical treatment. They are a patient, not a prisoner. So we shouldn't be using handcuffs unless they're under lawful arrest. Otherwise, we should be using medical devices, soft restraints, or other devices that are designed to help patients and not hurt them. I always see this one when a patient's agitated, spitting. They put this spit mask on them. They hold them down like this. And I get it. When someone's really agitated and aggressive, you need to stop them from, you want to stop them from hurting you, and you want to stop them from spitting on you, and you don't want them to hurt themselves. But this is really not okay for transport. If you find one of these on, you can use devices that are showing that you're trying to help the patient. Put an oxygen mask on them. You can tie it down relatively snugly or even tape it on the sides and restrain the patient so they can't pull it off. But now you're providing medical care to someone. You're giving them oxygen. You don't know if they have something going on with their brain that's affecting it. So we're providing this patient with oxygen. Again, we're treating them as a patient, not a prisoner. And oh, by the way, the mask also prevents them from spitting all over us. If we have to use medications, I would encourage you to at least try and start out at the lower doses of medications, as little as is needed to at least keep them calm. And remember, the goal in transport is just to prevent them from hurting you or themselves. They don't have to be completely out of it. They don't have to be completely sedated. It just has to be enough to prevent them from hurting themselves. And there's been a lot about ketamine in the news media. In the state of New Mexico, it is within the scope of paramedics, if they have a special skills assignment here, to give ketamine at a fairly hefty dose intramuscularly to stop someone who's agitated and aggressive. Up to this dose is reasonable. It is also reasonable to go a little bit lower if you think it's appropriate. And I always encourage people, and this is on a national scale, and this is in accordance with a great talk that a gentleman I know named Ruben Strayer, who's an emergency physician, gave, reserving ketamine for patients who are so out of control, they are imminently like swinging at people, fighting you, straining. It takes like 5 people to hold them down, and you're like, if we don't get this person under control immediately, they are going to hurt themselves or they are going to hurt somebody else. If that's the case, okay. But that's really what I reserve this medication for, that situation and that situation alone. If we do it, again, treat them like you're concerned about their airway, because you should be. Treat them like a patient that's undergoing sedation. Follow your protocols for a patient that's been sedated. I treat these patients like they're patients in the emergency department. I will ride in with the EMS team or provide direct supervision sometimes, and I'll act like this is a patient who I'm concerned about their airway and may even have to intubate. I'll get out the suction and get it prepped. I'll put an oxygen mask on them and put nasal prongs on them. I'll have airway equipment out and immediately available in case things go south. In a second's notice, I can go ahead and get out my BVM and support that person's respirations. I sit them up, I don't lay them flat, and I never, ever, ever put them on their stomach, hog tie them, or anything along those lines. And always monitor and watch their blood pressure, SATs, heart rate, and end tidal. And end tidal, like they were a patient in the emergency department that I was providing procedural sedation for. These are possibly the most dangerous patients because they have something going on that was causing them to be crazy and fight you and be agitated, and now you've sedated them so they can't clearly talk to you, they can't move around, and they are at risk of potentially getting too much medication on board and having breathing problems. So watch these patients like hawks, demonstrate that you're treating them like patients, not prisoners, and have everything ready for the worst case scenario. Finally, these situations are super difficult sometimes and very convoluted. I've gone over some cases, but man, oh man, they run the spectrum. So if you find yourself in these situations, always feel free to call for help. Feel free to call medical direction or your medical control people at the hospital you're delivering the patient to discuss it with them. And I always tell people, at least here in New Mexico with our services, we will always have a doctor on call, an EMS physician on call for our crews. So if you're in doubt, just give us a call. That's what we're here for. We're happy to talk through the situation for you so we can figure out the thing that's safest and best for you, the service, and the patient, first of all. So in summary, um, patients have the right to refuse, and they can if there's no clear threat to their life and they have capacity to make decisions. Capacity is more than just, hey doc, they're alert and oriented times 4. Have a short conversation with them. Talk to them about what's going on. Ask them their concerns, why they don't want to come to the hospital, and very clearly explore in depth that they understand the risks and they accept and appreciate those risks and they accept those risks. If you have to force transport, be careful for your safety and for theirs. Use the least force necessary or the least force to apply the restraint if necessary. Treat them like patients, not prisoners. So feel free to reach out to me with any questions or concerns. Thank you guys so much for your time and attention, and I appreciate what you do. Stay safe out there.